renal. Okay, as you know, the renal failure is end-stage renal disease that affects different type of patient for different causes. Sometimes the patient may have renal diseases such as the infection or autoimmune disease or trauma or whatever the cause that may lead to renal failure. Sometimes we have what is called the chronic kidney disease. Sometimes occur or associated with diabetes mellitus, so it causes the diabetic nephropathy. Whatever the cause of the renal failure, we after diagnose the patient, and the patient was treated on long period, maybe on the renal dialysis, and with the revolution of surgery and development of urology nowadays, we can do the renal transplantation with organ transplantation that develop in worldwide, and in our country there is a good experience for the renal transplantation. So what I mean by the renal transplantation is the procedure of choice and the most cost-effective strategy for the management of patients with end-stage renal disease. So we say it is a cost-effective. Put two red lines under that. We mean the patient, if present on the period of dialysis, it will cost-effective, and it make stress and a long loss of, because the patient may need 2 to 3 times renal dialysis or per week. So the renal transplantation is a good choice and a cost-effective for management of this end-stage renal disease. Successful renal transplantation is associated with substantial improvement in the quality of life, significant reduction in the morbidity and mortality from the end-stage renal disease. So it is a magic solve for this problem of end-stage renal disease, because it decreases the morbidity and mortality, and also at the same time it improves the life quality of the patient, significantly reduce the need for medical need or medical aid if the renal transplantation success. Previously, the outcome of patients with chronic renal failure is dialysis to get rid of waste product of metabolism, nitrogen and non-nitrogenous substance, either by peritoneal or hemodialysis. Kidney normally responsible for weight, number 1, water and electrolyte balance, maintenance of acid-base balance of the body, excretion of waste product, urea, uric acid, and creatinine, production of erythropoietin necessary for erythropoiesis, and renin secretion, and hydroxylation of vitamin D3 to 125 dihydroxy cholesterol, which is essential for bone. So it is the function of the kidney. So the patient with renal failure or chronic kidney disease affect all dysfunction of the kidney. So the patient may come with anemic, because it decreases the erythropoietin production. Also, the patient come acidotic because of accumulation of the nitrogenous substance. And also the patient may come with sodium potassium imbalance, so it had hyperkalemia, uremic, and had hyperkalemia because of affected secretion of the renin. And also the patient may come with osteoporosis, or because they affect the cold cholesterol. So the patient with renal failure have generalized edema, earthy color, acidotic breathing, hyperkalemic, and also uremic. Selection and preparation of the recipient. How we can select a recipient, that a donor, recipient of the kidney. The causes of the renal failure include, as I said previously, 36% it is diabetic. So it is called the diabetic nephropathy. 36%. More than 1/3 of the all patients complain from diabetic nephropathy. Hypertension, nephrosclerosis. Hypertension, nephrosclerosis, 30%. And also chronic glomerulonephritis. 24%. And autosomal dominant polycystic kidney disease. Autosomal dominant polycystic kidney disease. As we say in the previous lecture, we have two types of the polycystic kidney disease. We have autosomal dominant and autosomal recessive. So a patient may develop renal failure in 12% of autosomal dominant polycystic kidney disease. Renal failure in children. Renal failure in children. So it is less than 18-year-old. Congenital urological condition, hydronephrosis with obstruction or congenital atrophy. As major cause, 45% of renal failure. Contraindicated for renal transplantation. Contraindication for renal transplantation. Those recipient is contraindicated by diminishing the results of certain tissue type mismatching. Base is donor specific blood transfusion. Nowadays, with the era of cyclosporine and erythropoietin, blood transfusion no more needed. Pre-transplant bilateral native kidney nephrectomy. Their student maybe someone asked, if we do renal transplantation, the patient's own kidneys should be removed? No, no. But sometimes there is a specific indication for this surgery. So if one asks the owner, the patient's own kidneys should be resected or should be nephrectomized before surgery? No. جواب no. ما يحتاج ترفع الكلات الأصلية إلى وبعدين تسوي renal transplantation. No need. But sometimes we have an indication to do this surgery. What is the indication? Put this in your mind, please, there. Seldom required common indication include infection, something like hydronephrosis, a huge kidney filled with pus. 2, malignant disease. 3, medically uncontrolled renin-mediated hypertension, nephrotic syndrome, other less common like polycystic disease. So it is the indication for nephrectomy before or during renal transplantation. Bilateral laparoscopic nephrectomy has obvious advantage over the open approach. Selection of donor. How we can select a donor. Donor, it means the يعني متبرع. Recipient هو البيشنت اللي راح يستلم الكدني والدونر هو المتبرع. We have a different type of donor selection. Living donor, related, unrelated, and also cadaver and living donor. So we start with the living related donors. Living related donors. يعني شنو؟ يعني متبرع عايش alive and related to patient. أخوه، أبوه، أمه، أخته، ابن عمه، related. Living related donor. The potential donor must be free of any condition that increase the risk of any complication from operation, diminish the function of the remaining kidney, or change their baseline quality of life. First order, living related donors continue to provide significantly higher success rate in renal transplantation than cadaveric donor. Okay, so the best one, it is the living related donor. Living related donor. It is the best choice as a donor. And then living unrelated donors. Living unrelated donors. A live donor, but it is not related to patient. Living and related should be considered only when medically and ethically appropriate to circumvent the worldwide shortage of organs from cadaveric donors. It is medically acceptable if better results can be expected compared with cadaveric renal transplantation. It is ethically appropriate for enduring relation between the donor and recipient exist, such as spousal donation, when these criteria are used. The result of living and related donors superior to cadaveric because of excellent physiologic quality, no reservation of ischemic injury. So the second base, it is the living and related donors. يعني كل ما كان الدونر healthy wealthy have no surgical or medical comorbidities, non-smoker, non-drinker, have no hypertension, no hyperlipidemia, it is better, no autoimmune disease, no stone disease, no chronic infection. We should check all these conditions before select the patient for donation. So because the cadaveric kidney transplant have a time for ischemia injury, even so in the best centers and in the based hospital based renal transplant centers, there is a problem with ischemic time. In the world or in the developed countries, in the developed or European countries, we have sometimes donation center that have a list for the patient who wait for renal transplantation and all the informations of these patients present in these centers. So when there is road traffic accident or patient falling from height or whatever the trauma, the traumatic patient when reach brain death or other patient, so they are ready for donation. So there is a close contact and short time for preparing the donor and the recipient in this developed center for renal transplantation. So the patient will get or reach the best medical advice at short time to decrease the ischemic period. Cadaveric donors should not have any generalized disease that could adversely affect renal vascular integrity or perfusion, such as a chronic hypertension. مثل ما حكينا بالبداية قلت لكم هذا البيشنت لازم ما عنده الكرونيك ديزيز مثلا الهايبرتنشن، الدايابيتيك، malignant disease, okay, or chronic infection or autoimmune disease. For the patient should be, or the donor not have these diseases. So and older donors or those with a questionable systemic disease such as hypertension, renal biopsy should be considered. A biopsy finding of significant glomerulosclerosis, entemal hyperplasia, interstitial fibrosis, a tubular atrophy, or evidence of diminished intravascular capability rendered the donors unacceptable. High risk for HIV patients are unacceptable donors. As I said in the beginning of the lecture, patient with HIV infection, it is unacceptable donors. Okay. Now we go for compatibility. What I mean by this يسموه تطابق، فحص تطابق. مثل ما تشوفون يعني إذا تشوف البيشنت prepared يقول لك احنا راح نسوي له فحص تطابق. تطابق اول شيء يبدي يعني نسوي له الاي بي او بعدين نسوي له الاتش ال اي اوكي بعدين نسوي له تشو compatibility. فكله يعتمد حتى نقدر نسوي good selection for donation. Good selection for donation. The principal histocompatibility antigens are major histocompatibility complex, MHC, major histocompatibility complex, and blood group, ABO-RH, blood group. So at first we start do the ABO-RH and then go for the major histocompatibility complex, major histocompatibility complex. The human major histocompatibility complex isolated on the short arm of chromosome 6 and include the genetic loci of A, B, C, and D, DR, DQ, and DP. These genetic loci code antigen specialties which are detected on peripheral blood lymphocyte and known as human leukocyte antigen, or HLA. As I said, there is an HLA, human leukocyte antigen. This is very important for histocompatibility. Very important for histocompatibility. So it's done in the special lab by find the loci responsible for tissue, human or tissue leukocyte antigen, اللي هو human leukocyte antigen, HLA. So the patient need ABO HLA. If it is compatible, we go for donation. The antigens of genetic loci ABC can detected by tissue typing serology, while antigen of D locus is detected only by mixed leukocyte culture, MLC, mixed leukocyte culture, which is done by mixing lymphocytes of donor and recipient in a tissue culture, and it takes about 5 days until we take the result. It measures cell-to-cell reaction of lymphocyte. It measures cell-to-cell reaction of lymphocyte. Okay? A, B, C, we can do by tissue typing serology, but D, locus, should we do leukocyte culture, mixed leukocyte culture? So we take leukocytes from the donor, leukocytes from the recipient, take them and put them in a tissue culture. And it take about 5 days until we take the result. It measures cell-to-cell reaction of lymphocytes. This culture is not particular for cadaveric kidney because it takes long time and best way to preserve the kidney, usually to no more than 2 days. So why we can tissue culture for cadaveric renal transplant? Because it takes a long time, so we cannot keep or protect the recipient, the donor kidney for longer than or more than 2 days. HLA locus is the most important one in these reactions. So if the result is positive, indicate incompatibility. If negative, compatible, and transplantation is possible. Operative procedure. How can I do the renal transplantation? Donor operation. Routine nephrectomy. Give dopamine and chloramazine for donor. Develop hypotension and impaired renal function. Preservation of kidney rarely necessary. Recipient operation, clear the external and internal iliac vessels from lymph node and adipose tissue. Transplanted kidney based position is in the iliac fossa. On the right side, the best site for putting the donated kidney is in the right iliac fossa. The renal artery is anatomized to external or internal iliac artery. It is best to do anastomosis to the internal iliac artery, but sometimes we use the external iliac artery. Why? Because the external iliac artery go for the external and go as the femoral artery. So we sometimes avoid injury to this or ischemia to the lower limb. So it is better to do to internal iliac artery, but if there is any problem with that or we cannot do anastomosis, we can use the external iliac artery. The vein to external iliac vein, okay, and finally the ureter is implanted to the urinary bladder, okay. When we do a surgery for renal transplantation, it is better to get the left kidney. The nephrectomy from the donor, it is the left, we get the left kidney and transplanted to the right iliac fossa of the recipient, okay. Donor kidney, the left one. And then why we use or better to use, we can use the right, but it is better to use the left one. Why? Because the vein longer than the right one. The left renal vein longer than the right one. So it is better. It is not absolute indication, but it's better to use the left one and put in the right iliac fossa of the patient, and then do anastomosis of the renal artery to the internal better, and sometimes we use the external renal artery, and then the vein to the external renal vein بالعكس, والureter is implanted to the bladder. Ureter is implanted to the bladder. Immunosuppressive therapy 24 hours before operation and after transplantation for results of for rest of his life, except in case of transplanted from identical twin. Okay, there, with this in your mind, the patient with renal transplantation should put on immunosuppressive therapy for his rest of life, except twin. إذا عنده أخوه توأم والتوأم المماثل ممكن نستخدمه بدون الحاجة إلى long term immunosuppressive therapy. The drugs, azathioprine 3 mg per kg cause bone marrow depression. Cyclosporine, steroid, prednisolone steroid, anti-lymphocyte globulin, which is polyclonal non-specific drugs, antibody purified to IgG, OKT3, which is monoclonal antibody against a specific T cell antigen, and general fluid balance. Urinary output is measured hourly and replaced with dextrosaline. نقعد نحسب الانبوت والاوتبوت especially in the first 72 hours. انت قاعد تحسب بالضبط ايش قاعد يدخل المريض فلويد، ايش قاعد يطلع من عنده فلويد، urine output, do balance between them and put the patient on the immunosuppressive therapy and see. Complication. At first, technical, include vascular, urinary extravasation, or obstruction to the outflow of urine or lymphatic obstruction. Lymphocyte may occur, which is a big mass, can be palpated on abdominal examination due to collection of lymph, occur as a result of dissection of lymphatic vessel during surgery. It does not affect the function of kidney, but require treatment which is done surgically by draining the lymphocyte to peritoneal cavity. So the first complication, it is technical, vascular, or ureteric problem, and also sometimes we have lymphocyte accumulation of lymph around the transplanted kidney. 2. Infection. The most common cause of death after transplantation occurred due to the use of immunosuppressive drug, so the body infected easily with impaired defense mechanism. Steroid and high dose delay healing and mask classical physical sign of disease, such as the pneumonia or acute abdomen. Example of those opportunistic infection are pneumocystic carni, pneumonia, Monelia, cytomegalovirus, and Epstein-Barr virus. اثنين هاي كتبوها شباب. Epstein-Barr virus, Epstein-Barr virus, cytomegalovirus, and staphylococcal infection. Okay, also high doses of steroid may cause osteonecrosis, a vascular necrosis of the neck of the femur. Say, students, all these complications occur because of immunosuppression and high dose of steroid and immunosuppression, and increase the possibility of infection, and also the infection of a strange type of infection. Normally in the patient it is or in the healthy patient it is rarely occur, such as the this list of problem, and also it caused the avascular necrosis, such as the avascular necrosis of the neck of the femur. Acute tubular necrosis. Acute tubular necrosis is the commonest cause of post-operative anuria. Tubular cast may be seen in urine. Hemodialysis may be necessary. Will recover spontaneously. So, causes of the acute anuria after renal transplantation, it is caused by acute tubular necrosis. 4. Rejection. All transplants have some degree of rejection. The severe form is. Now we get the type of rejections. Okay. Now go for the type of rejection. At first, the hyperacute rejection may occur within minutes of completion of operation. This is seen in ABO incompatible or in recipient sensitized by multiple blood transfusion. When occur, it is associated with intrarenal coagulopathy and cross platelet aggregation. So the first one, it is the hyperacute rejection. ليش يصير عندنا في حالة الاي بي او incompatibility or the patient have multiple blood transfusion. اوكي يصير on bed بعد الجراح ده يشتغل ويصير الكدني bluish discoloration, no urine output, so it means there is a hyperacute rejection. 2. Acute rejection, which may occur even with HLA compatibility and may be seen 3 months after transplant. So hyperacute rejection على السرير بعد المريض بالعمليات on the operating table. Acute rejection may reach from first day to 3 months. نسميه acute rejection. A chronic rejection occur many months after transplantation associated with arterial damage in the kidney. Okay. Feature of rejection in general. شلون اقول هذا صار عنده rejection. Decrease urine flow or decrease urine output. Increase blood urea serum creatinine. Tenderness on examination over grafted kidney. And sometimes fever and hypertension. Diagnosed by radioisotope scan and renal biopsy done to differentiate from acute tubular necrosis. So it is very important to differentiate between acute tubular necrosis and rejection. Acute tubular necrosis may resolve spontaneously, but rejection we should get our facility to get rid of it. Rejection is treated by extensive immunosuppressive therapy. شوف شو يسوي؟ أول شيء أصعد immunosuppressive therapy. Okay. Sometimes external radiation restricted to the transplant margin or even splenectomy in case of the leukopenia. Okay. ايش راح اسوي له حتى get rid of rejection. Differential diagnosis of both transplant oliguria. Very important. Differential diagnosis for post. اجى المريض قال لك والله ادرار ما يطلع، نشوفه داخلينه احنا بالاي سي يو بوست ترانسبلانت شفنا عنده اوليجيوريا. شنو differential diagnosis؟ acute tubular necrosis, rejection, obstruction of the collecting system, and infarction due to false operative technique. Okay, thank you there. Maybe this the last lecture for this year. Any question, please? Anyone have a question, please? Yes.